So good afternoon and thank you everyone for joining us for this PANCAP webinar on addressing HBV as a public health issue beyond immunization, scaling up HBV testing and treatment. And my name is Timothy Austin, Communications Specialist within the PANCAP Coordinating Unit in Georgetown, Guyana, and I'm pleased to be your moderator for today's webinar. Let me extend a warm welcome to you on behalf of the partnership and PANCAP's director, Mr. Derek Springer, and our knowledge coordinator, Dr. Shanti Singh Anthony. PANCAP continues to serve as a knowledge hub for the region, and through this forum, we are pleased to share new knowledge and skills to build the capacity of our members and stakeholders. This webinar is designed to provide knowledge on the Hepatitis B Virus, HBV, as a public health issue. It will also highlight the importance of scaling up HBV testing and treatment. And before we start, I want to share with you a few housekeeping points to note. Your mics are muted. If you have questions as the presentation progresses, please note them down in the sidebar. Following the presentation, there will be a question and answer segment. Please type your questions in the comment section. And finally, the webinar will be recorded and shared on the PANCAP website, YouTube channel, and all of our social media platforms for the benefit of the greater partnership. Today, our facilitator is Dr. Nick Walsh, Regional Advisor for Viral Hepatitis at the Pan American Health Organization, WHO, Regional Office for the Americas, based in Washington, D.C. He's a medical doctor with qualifications from the Royal Australasian College of Physicians, with a clinical background in the screening, care, and treatment of hepatitis, in particular B and C, and HIV in Australia and Cambodia. He also has substantial clinical experience across addiction medicine, infectious diseases, emergency and internal medicine, and has worked extensively in Indigenous communities in Northern Australia. He has a public health background with particular experience in HIV and viral hepatitis in the Asian Pacific and Australia. He holds a PhD in epidemiology from Monash University. In 2006, he was a consultant with the World Health Organization in the HIV department, Global Hepatitis Program, Mental Health, and Substance Abuse. Dr. Walsh was also the focal point for viral hepatitis at the World Health Organization Regional Office for the Western Pacific in Manila and the Philippines in 2014, before moving to PAHO in 2017. Dr. Walsh, I want to say again, thank you so much for joining us. And I know a lot of our PANCAP members and stakeholders are looking forward to this presentation. We're seeing a lot of good feedback when we announce it on our social media platforms. So I'm so pleased and privileged to have you here this afternoon.
Excellent. Thanks, Timothy. Can I just check the sound? Are we good?
Perfect. I can hear you clearly.
Excellent. So I'll go ahead. No, thank you very much. It's a privilege to be here. This is the second webinar we have done on hepatitis, hepatitis B, in fact. Last year we had one as well. It's a real privilege to be here again. And I just want to check with Timothy. Do we have a poll, a question that was going to go around?
We'll just have this survey at the end of...
at the end. Okay,
right.
Great. So I'll just get started. So I've been working as a regional advisor for viral hepatitis here for the last 2 years, 2.5 years. And what I'm going to present is the current status of the epidemic and what our key recommendations are, with particular focus on the Caribbean, of course. I did want to, just at the very beginning, look more broadly at PAHO's comprehensive support to addressing hepatitis, because it is multi-pronged, and we work collaboratively with other teams, including health systems, the Strategic Fund. We work with communications. We work with the immunization team. Specifically, we're supporting countries on national planning, the development of national plans for hepatitis, an estimation of the disease burden and the investment case through mathematical modeling, which has not been done in Caribbean just yet. Access to medicines for hepatitis B, hepatitis C, diagnostics, of course, rapid tests for hepatitis B and C, as well as PCR confirmation for those two infections. We've been focused on over the last couple of years on improving data systems, and I will mention the Global Hepatitis Reporting System, which is opened up for the second year. Obviously, advocacy, community participation, and finally EMTCT+, which is an initiative to align HIV, hepatitis B, Chagas, and syphilis maternal child transmission prevention through the common maternal child health platform. So together, these are the activities that we engage with at a national level, and I will present some of this work today. The key documents I hope have been shared. If not, they will be shared, which we are going to base, on which I based the PowerPoint presentation, are the Global Health Sector Strategy for Viral Hepatitis, which was really the first agreement which mentioned elimination as a public health goal by 2030 in 2016. This runs until 2021. The goal is the elimination of viral hepatitis as a public health problem by 2030. For the globe, also, of course, we have aligned our regional plan of action for viral hepatitis here in the Americas, which in fact finishes this year with the global strategy. We have a new document out this year regarding hepatitis strategic information, the consolidated guidelines. That's available on the web, and you should have the link. We launched last year the Global Hepatitis Reporting System, which is a mechanism to report at the national level data regarding the cascade of care in country and key policy positions of countries. That has been opened up. It's web-based through the DHIS2 platform. And this year's data for last year should be entered prior to November 30. Finally, we have the testing and the treatment guidelines for hepatitis B, which are also available on the web from WHO. Obviously, our position at PAHO is that we adopt these guidelines. Speaking about the prevalence of hepatitis B in the Caribbean, we did estimates in 2016 that there were approximately 900,000 people chronically infected. Now, we're including Hispaniola in these estimates, which does increase the burden substantially because of the population, 20 million people on that island. So if we do exclude Hispaniola, obviously the number of people chronically infected is less. And we don't really have good in-country data. The proxy data suggests the prevalence around 2%. We do have evidence from Guyana. It is about 2% of blood donors positive. It's a bit less in Trinidad, but we don't have very much data in other countries. Most likely, the actual prevalence is a little bit lower than this. But until we get good data to support these figures, we will have to make estimates with extrapolated data. As I mentioned, the Global Hepatitis Strategy has the goal to eliminate hepatitis B and C as public health problems by 2030, which means ostensibly a reduction in new cases of chronic hepatitis B and C by 90% and a reduction in mortality by 65% based on 2015 levels by 2030. We also have a number of programmatic goals. 90% of people infected be diagnosed, and that 80% of those be treated. We have a vaccination coverage goal, of course, birth dose being the most important, a blood donation screen, universal screening, of course, and safe injections in health systems goal. The plan of action for the prevention and control of viral hepatitis, I will put it here. However, it is ending this year. There is not a plan to have another regional action plan for a variety of different reasons. We will continue to work in these areas, but going forward in 2020-21, we will be continuing just to implement the key recommendations of this strategy and trying to attain the global elimination goals. There are 5 areas of work in the plan of action: promoting an integrated comprehensive response, fostering equitable access to prevention, clinical care, of course, strengthening strategic information, and of course, support, laboratory support. And the key thing about laboratory support to hepatitis is that we're really not talking about specific hepatitis laboratories, but looking at existing infrastructure for HIV, TB, etc. And where can, blood donations, and where can we build into these existing infrastructures the capacity to test for hepatitis. So we have to remember, of course, in hepatitis, as in most infectious diseases, that we're both talking about prevention and treatment. We're talking about, with regard to hepatitis B, the uninfected population, the susceptible population being vaccinated. And for hepatitis B, obviously, this means, given the risk of chronic infection, if you're infected as a young child, less than 5 years, is up to 90%, compared to the adult, where the risk of chronic infection following acute infection is only about 2%, that we need to vaccinate the susceptible population very early in life. Our recommendation, of course, is a vaccine within the first 24 hours of life, and that needs to be universal. That's our recommendation, followed by 3 doses of the hepatitis B vaccine. In terms of the actual cascade of care, we talk about estimating the potential population. Obviously, those people who are diagnosed, we have numbers, we have percentages, the number of people being treated, retained, and of course, suppressed. So the treatment for hepatitis B is not curative, but if you can reduce the viral load through treatment to a level which is undetectable, then you can reverse the liver disease associated with hepatitis B, and you can reduce markedly by 80% the risk of liver cancer. So there are 3 specific interventions we're interested in, as I mentioned: vaccination in this cascade, the diagnosis through testing, and treatment. Hepatitis testing guidelines were in fact integrated B and C guidelines released by WHO in 2014. And they had the recommendation of identifying who to test, how to confirm, and then how do we get linkage to care? How do we promote people who are diagnosed being linked to care? Well, in terms of the population to test, we do recommend in general where the prevalence is greater than 2%, i.e. intermediate or high prevalence, that the whole population is tested for hepatitis B or C. Now, in the Caribbean, it does not appear to be the case that prevalence is higher than 2%. So in this situation, we would recommend focused testing on most affected populations: those with clinical suspicion of viral hepatitis, family members, children of people with viral hepatitis, sexual partners, of course, healthcare workers, critical. And particularly for hepatitis B, we recommend routine universal antenatal testing, hepatitis B surface antigen during pregnancy. How to test? We recommend just one test for screening. This is an antigen test, hepatitis B surface antigen test. Can be a rapid test, can be a ELISA test, EIA. So one serological test, which meets the minimum performance requirements, and then the individual is diagnosed for hepatitis B. Following that, then you need evaluation for whether this person needs treatment or not, and that will include a viral load. In terms of linking patients to care, we do recommend that there'd be on-site or immediate testing for rapid test testing for hepatitis B, same-day results. So people are tested, they get the results on the same day, and then you can get people more likely to enter the treatment cascade. We do recommend peer workers. We do recommend testing by laypersons who are, well, lay health workers. So this is a concept of task shifting. We recommend facility-based testing, and we do recommend community-based testing as well. In terms of treatment, and I really need to emphasize this point, the fact is, despite effective treatment for hepatitis B, and we are talking about a treatment where there is no resistance, a treatment that reduces the risk of liver cancer by 75%, a treatment that reverses liver disease, that extends life. We have very little treatment available in the Caribbean. In fact, in most parts of the region, there is very little availability of hepatitis B treatment. There are some countries, of course, where this is an exception. And for me, as a physician, as a clinician, I worked 15 years in clinical medicine before joining 5 years ago WHO. It is not acceptable that at this stage, 2019, where there is effective treatment which prevents cancer, that there are people that are not receiving treatment. The treatment is very cheap. It is approximately $3 per month. It can be a little bit more expensive and depending on the patent status of tenofovir, but it is extremely cheap. And the main point is that hepatitis B treatment, hepatitis C as well, but hepatitis treatment is liver cancer prevention. We are preventing cancer here. In fact, so if you look at the cost of diagnosing and treating liver cancer and the effectiveness of the treatment of liver cancer, clearly we have a good argument as to why we should be diagnosing people early with hepatitis B, getting people onto antiviral treatment to prevent liver cancer. Obviously, if you get liver cancer, the outcome is usually very, very poor. What do we have in hepatitis B? Well, we have we don't have this ideal scenario. The ideal scenario would be that we have a highly effective vaccine and we have curative treatment. We do not have curative treatment at the moment. We do have a highly effective vaccine. So we're working at two ends of the spectrum. We are recommending vaccination within the first 24 hours of life and universal vaccination for hepatitis B to reduce the susceptible population and prevent maternal-child transmission. And we have a treatment which is non-curative. Unfortunately, treatment is lifelong, but as I mentioned, it is very inexpensive, and so it is not unaffordable at all for health systems. Now, this is in contrast to Hep C treatment, which is very expensive currently, about $4,000, depending on the country per treatment course. If you can get access to generics, of course, that is much cheaper. So what do the guidelines say? Now, I'm presenting the 2015 clinical treatment guidelines for hepatitis B from WHO. Now, why am I presenting guidelines that were written 4 years ago? This is because there is no change in the recommendation for treatment, and why it is so important that we scale up existing recommendations. We have all the tools, we have all the information. We just need to implement to scale up access and treatment of hepatitis B. The key recommendations in these guidance are that we use non-invasive tests for staging liver disease. That's like the APRI score or the FIB-4 score, which are calculators or calculus that are used to estimate the extent of liver disease. These calculators are available on the net. Who do we treat? Well, we treat people who have cirrhosis, we recommend treatment to individuals who are over 30 with high viral loads. What treatment do we use? Well, tenofovir and entecavir are the key drugs that we use. Both have a very high barrier to resistance. We do not recommend lamivudine, adefovir, all of the other antivirals. We do not recommend. Why? Because there are cases of resistance. So tenofovir and entecavir. How do we monitor? These are detailed in the guidelines. When to stop. Lifelong treatment for everyone, essentially, who is started on treatment. Of course, there is prevention measures. So, why is it important to stage liver disease in individuals diagnosed? We are not recommending at the moment that every individual with hepatitis B surface antigen who's positive for hepatitis B surface antigen is treated for hepatitis B. And so if a country has a population, for example, of 10,000 people with hepatitis B, we do not have to treat every single one of those people. Why is that? Well, people with low viral loads, younger individuals, are unlikely to develop cancer in the near term. And so the value of treating is not worth the cost and the other associated side effects of medication and engagement with the health system. So what we want to do is we want to diagnose, and then we want to work out who do we need to treat now. There are some estimates in the literature. We did a recent systematic review, meta-analysis systematic review, trying to estimate, according to WHO recommendations, what proportion of the population would be eligible for treatment. And the answer is about 22%. So of 10,000 people, we estimate that if a country has a population of 10,000 people with hepatitis B, we would estimate that about a quarter, say 2,500, 2,500 individuals would need treatment now. So why do we recommend treatment of those who have high viral loads, those with cirrhosis, and those who are older? This is the most well-known cohort, hepatitis B positive cohort in the world. It is in Taiwan, China, a special autonomous region of China. It's called the REVEAL cohort. It's been going for a number of years now. They took a whole bunch of people with hepatitis who were hepatitis B surface antigen positive, and they followed them over time. They looked at the gender, the age distribution of the or the age cohort, the age groups of the individuals. What was their baseline DNA, and what was their baseline ALT? And they looked over time at the incidence of hepatocellular carcinoma, because this is what we're trying to save lives by treatment. So, and they found that if the reference, there's no difference in between. If we look at age first, if the reference is 30 to 40-year-olds, there is a small increase in the risk of liver cancer in those 40 to 50, but this increases markedly with age. So we, in fact, chose a younger age as an age cutoff for treatment. We chose 30, only because the literature does not show any increase in liver cancer risk below the age of 30. So we've chosen 30. Others have chosen a higher age cutoff. But certainly, if you have a patient who's 50 with hepatitis B certain surface, you'd be very concerned that this person doesn't need treatment right now. The other component is, of course, the viral load. And you can see here, I've highlighted that the base was a low viral load. The reference was a very low viral load, less than 300. If you look at the copies per mil, less than 10,000, really there was no significant difference between having a very, very low viral load and having a viral load less than 10,000. But once you start to get up above 100,000 copies, up to 1 million copies, then you start to see a very large increase in the risk of developing liver cancer. And again, you can see that there is a grade effect of elevated ALT. So these are the three components we feel contribute most to the elevated risk of liver cancer, and hence our recommendation. Now, worth noting that the risk of liver cancer in males is higher than in females as well. So how do we, we didn't do the poll at the beginning to see what positions participants have and what capacity participants in this webinar are engaged in hepatitis B work. But essentially we classify, so this, I apologize if everyone's fully aware of the of cirrhosis and the progression of liver disease. But essentially we have a scoring system to describe the amount of liver damage, which is the amount of tissue scarring in the liver caused essentially by viral hepatitis, in this case hepatitis B. And it goes from 0, which is no fibrosis, no scarring, to F4, which is scarring to the extent where you affect the function of the liver. Now, so F0, 1, 2, 3, there is no functional deficit. The liver is functioning essentially normally. F4, you have functional deficit. The liver is not functioning normally. F1, 2, 3 are various stages of fibrosis, the extent of fibrosis in livers. And so the concept which I think is important to understand here is that the the more scar tissue there is in the liver, the stiffer the liver becomes, and so it loses elasticity, and that is one of the ways we can measure how healthy the liver is, how elastic it is. So our recommendations in terms of staging liver for liver disease, really the key determinant is the key thing we need to determine is, does this person have cirrhosis or not? How stiff is the liver? Do they have any functional liver deficit or not? Now, we have a number of different scoring systems which are non-invasive. So when we talk about non-invasive, we're talking about everything apart from the liver biopsy, because clearly liver biopsy is not practical in many settings. It's invasive, it hurts, you've always got the risk of infection, you've got the risk of bleeding, it's complicated, you can do a biopsy the wrong part of the liver. So we have APRI score. The APRI score, as I mentioned previously, it's a ratio. It's a ratio of AST to platelets, and there are calculators on the net. FIB4, same, but also takes into account ALT and age. FibroTest is another biochemical marker calculator, which takes into account 5 serum markers. And then we have FibroScan, which is transient elastography, which is an ultrasound device which measures the elasticity of the liver. Now, in order to measure cirrhosis, it's really a dichotomous variable we're looking at. You know, does this person have cirrhosis or not? So we don't need to know if they're F2, F3, or 2, F1. It doesn't matter. Do they have cirrhosis or not? So for this, APRI is sufficient. FIB4 is sufficient. We are recommending that APRI be the preferred non-invasive test to assess for the presence of cirrhosis, and the score should be greater than 2 in resource-limited settings. Where elastography is available, we're recommending it be used. Regarding a hepatitis B antiviral treatment, in individuals older than 12 years, which of course includes all adults, we recommend nucleotide or nucleoside analogues, which have a high barrier to resistance, tenofovir or entecavir. It's a strong recommendation, a moderate quality of evidence. So we have sufficient evidence to be able to state that these are the 2 drugs that are more effective than other drugs. Nucleoside or nucleotide analogues with low barrier to resistance, lamivudine, adefovir, talbivudine, etc., lead to drug resistance. They're not recommended. People need to be taken off these drugs and put onto tenofovir or entecavir. Where there is resistance, tenofovir is the drug to switch to. So it's really extremely simple. Initiate people on tenofovir or entecavir. If you see resistance, which does not exist for tenofovir, there have been some recorded cases in entecavir, or if the individual is on another drug where there is resistance, go to tenofovir. Putting everything together in an algorithm, I'd like to show you our recommendations. I believe these are very straightforward. You take the general population, screen for, or the population being screened. You screen for hepatitis B surface antigen, positive or not. Not positive, no infection. Positive, infection. Then the question is, do they have cirrhosis? What is their age? If the patient has cirrhosis, i.e. their APRI score is greater than 2, we recommend treatment immediately and lifelong. If the patient is less than 30 years, no treatment. Treatment is deferred. If the patient is greater than 30 years, we go to the next step. Is the ALT persistently elevated, i.e. more than 6 months? If it is not elevated, normal ALT, or if it's fluctuating up and down into the normal range, then there is no treatment recommended at this point in time. If the ALT is elevated, then we do the DNA. DNA greater than 20,000 international units. Excuse me. We recommend treatment. So we're treating 2 groups, as I mentioned previously. Cirrhotics, those aged over 30 who have elevated ALT, but more importantly, elevated DNA. One of the issues is in countries where DNA is not available. The HBV PCR is not available. Now, it is available currently on the GenExpert platform. There is a GenExpert cartridge for Hep B PCR, which is approximately $15 through the strategic fund. So if your country has a GenExpert machine, you can buy cartridges for Hep B PCR for $15 through the strategic fund. Obviously, most of the major platform-based tests do have DNA capacity as well. So there's HIV platform-based testing systems have the capacity for DNA that is more expensive than that of GenExpert, and there are other solutions as well. But where we do not have DNA access, we are recommending, in fact, that individuals without cirrhosis, so if you've got cirrhosis, you're treated. If you do not have cirrhosis greater than age 30, we do an ALT. If it's elevated persistently, regardless of hepatitis B E antigen status, we treat. So I think it's relatively clear, those two recommendations. Cirrhotics, and if you're non-cirrhotic, and you have an elevated ALT, check the viral load. If it's high, you treat. If there is no access to viral load, you can treat purely on the basis of a persistently elevated ALT. So I've been through these recommendations on treatment. Now, what do we do in terms of monitoring? Well, we recommend annual testing, ALT level. You do an annual APRI, we recommend that, annual surface antigen and annual e-antigen DNA. And we monitor adherence. Obviously, you don't take the drug, you're not going to get the effect. Regarding toxicity is very low, of course. We do recommend baseline renal function and assessment of baseline risk for renal dysfunction in all persons where we're initiating treatment. Of course, there is some association with renal side effects for hepatitis B treatment with tenofovir. And we do recommend that the renal function be monitored annually. What about hepatocellular carcinoma? Because, of course, this is why we're treating. In people with cirrhosis, we recommend abdominal ultrasound alpha-fetoprotein testing every 6 months. In people with a family history as well. And for those over 40 with a DNA greater than 2,000, so this is even in people without cirrhosis, with a viral load that may not be that high, we do recommend screening. In terms of when do you stop treatment, well, all people with cirrhosis should be treated lifelong. Basically everyone who's started on treatment should be continued lifelong. There are some certain situations where we can stop treatment. This is in people without cirrhosis who can be followed up, regularly monitored. If there's evidence of e-antigen loss and seroconversion to anti-HBe for at least 1 year after, and you've continued treatment for a year after this has happened. And of course, you've got to have normal ALT levels and persistently undetectable DNA. So this is the very small minority of individuals, probably about 3%. So in terms of the implementation of these recommendations, because this is really what it's all about, converting recommendations into individual patient care and scaling this up. We believe that each country should have a comprehensive national plan based on local epidemiological context, whatever the status of the current health infrastructure, and in the context of the current coverage of testing, treatment, prevention. Obviously, that will depend on local, national resources, and we're not talking about building new entities. We are talking about, this is but one module for the national health system. So the system itself, the national health system, should include the capacity for people to be diagnosed and treated for hepatitis B. Simple and standardized algorithms. We're in the process of working with PAHO, Sub-Regional Office for the Caribbean, to develop Caribbean-wide testing and treatment guidelines. I understand they'll be ready relatively soon. This is across the continuum of care. Strategies to strengthen linkage from testing to care, obviously. Integration of hepatitis testing, care, and treatment with other services. So this is where we don't want to, as I mentioned, new infrastructure necessarily. We want to build on what is existing at the moment. What HIV and TB, etc. capacity is there in the system? How can we value add on these existing services to also include hepatitis? We believe in decentralized testing and treatment services. There is no way that specialized services will have the capacity to treat all people, test and treat all people with hepatitis. We need to decentralize to primary level healthcare. And this is done by the training of individuals at the primary healthcare level, doctors and nurses, task sharing, so this can be shifting completely or sharing, where there's a shared care plan between specialists and primary care providers, and differentiated care strategies. So obviously, we still do need specialist care for those individuals with complicated liver disease, cirrhosis, compensated cirrhosis, decompensated cirrhosis, liver cancer, no question. But the earlier stage cases, F0, 1, 2, 3, etc., can be managed without specialist care. We need community engagement, peer support, of course, particularly to vulnerable populations, high-risk populations, which are the key populations in HIV, more or less. We are working with the PAHO Strategic Fund to support more efficient procurement and supply management, drugs and diagnostics, including rapid tests, and data systems to monitor the quality of individual care and coverage. And this is where it's important that countries also record the cascade of care. How many people, what's the estimated population with hepatitis? How many people have been diagnosed? How many people have been treated? And how effective is that treatment at the population level? So in conclusion, I'm going to finish here. Hepatitis treatment, hepatitis B treatment is cancer prevention. Simple testing and treatment algorithms are possible and recommended. Treatment is not possible without diagnosis. We need to scale up diagnosis to the affected population. The monitoring requirements of hepatitis B at this stage are minimal. And we at PAHO stand ready to support any action to increase the availability of diagnosis and treatment in the Caribbean. And I would just mention that this year we are putting together the final report to the Regional Action Plan for Viral Hepatitis. We'll be calling on countries to report against the goals that we had set out in that initial action plan in 2015. And so we will be working with country officers to collect this data. We hope that the publication of the final report will be a positive one, and we stand ready to increase support as needed to scale up action to address hepatitis B as a public health problem in the Caribbean. Thank you very much.
Thank you so much, Dr. Walsh. You've given us a wealth of information on HBV testing and treatment. That was a fantastic presentation. But I just want to now open the webinar to questions from our participants. We have quite a few participants who have joined us this afternoon. So please type your questions in at that's the sidebar where you see there's the questions tab. You can type those questions in and we'll ask Dr. Walsh to respond to a few of those questions. So I want to open the floor to questions from our participants now. And while we wait on that, Dr. Walsh, I just wanted to ask you again. You mentioned that there was very little treatment for hepatitis B in the Caribbean. And
yes.
I can tell from the tone of your voice when you presented that particular segment, you're very passionate about that. You did say that it's not acceptable. So I know this is an issue that's very close to your heart. Do you want to just expand a bit more? Is this an issue that we can approach our policymakers about? How can we improve the situation where there's very little treatment for hepatitis B?
Well, look, yeah, I think I suppose the way the best answer to that question is that we have all the policy recommendations at the global and regional level available. We have the drugs, we have the tests, but in many places it's simply not available or being done. I had an experience. I used to work in Wipro in Asia. We worked with the Pacific Islands, and our experience was it was possible to scale up a treatment in island countries without question, but we need full engagement with clinicians, and we need to be proactive, us PAHO, in doing that. And so I guess what I'd say is I'd call on anyone participating today to, if you do have an interest in working with us to identify, test and treat individuals with hepatitis in a country of the Caribbean, please contact us. We have everything in place. We just need to start. And I think that one thing is, people say, well, we have to focus on the big countries of Brazil, United States, perhaps. No, the thing is, when you have a small country, a smaller population, you really don't have very many people to treat to make a massive impact in the epidemic in a smaller country. So it's very easy to have a real impact given the size of many countries of the Caribbean. And I'd encourage you to get in touch and see if we can change.
Great, thank you, Dr. Walsh. And I know that's an issue that is close to your heart. Do you want to just mention how you get in touch with we can get in touch with PAHO? Could you just tell us how can we do that? What's the best channel we can use?
Well, I think I'm trying to actually find the sidebar. I can't find the sidebar on my GoToMeeting. But look, I think we'd be happy to take direct communication, or I think in this case, perhaps through the CARICOM Secretariat, you could direct any questions and follow up directly to our email here in Washington. We have Sandra Jones in Barbados as our sub-regional focal point for hepatitis. I think if we can get communication through CARICOM or directly, that would be wonderful. So we're here, and Tim, I don't know, maybe we can coordinate something later on to or after this to facilitate that.
Sure, definitely. And of course, they would have been receiving emails from us. So if you want to send any, ask any more questions, or you want to make contact with Dr. Walsh or PAHO, please, you can use those email addresses. Of course, Sandra Jones is a close friend and partner to PANCAP as well, so we can get in touch with her. And you, of course, Dr. Walsh.
Yes.
Anyone sending us questions, we can get those questions to you. So you can send an email to Dr. Shanti Singh Anthony, who is our knowledge coordinator. You can send it to me as well, and we'll get those questions to Dr. Walsh or anyone from PAHO.
Absolutely. And I love hearing from the Caribbean because I'm Australian and I love cricket. And when I think of the Caribbean, I think cricket. And so it's refreshing. I love football too, soccer, but cricket's fantastic. And so we look forward to hearing from our fellow cricketers.
That's fantastic, and there's been a lot happening with cricket in the Caribbean. A lot of big matches right now, so this is the right season to be in the Caribbean. We're still waiting on some questions. I see there are quite a lot of persons who are participating with us this afternoon, but no questions have come in as yet. But while we're waiting, Dr. Walsh, you also mentioned that community engagement is and peer support is quite important to promote access to services. Do you want to expand a bit more on that?
Yeah, I mean, the idea is that we would, given the amount of knowledge, I mean, most people in the community think hepatitis B, well, it might be a virus, but it doesn't affect you. It doesn't have it's not particularly harmful. We would say we need to not only raise awareness in the general community, and this is people who are infected with hepatitis B having testing and treatment, being given the tools to spread the word that treatment is effective, but also through health systems. I mean, I think in general we need to scale up knowledge and the skills of our fellow medical, nursing, health workforce people, and so that's what we in fact try to do on World Hepatitis Day, July 28th. Each year we try to focus attention. We have a number of tools on the key components of the response, the key clinical and other points that health workers need to be aware of. Those tools are on our website. So really it's worth both a focus on the community, the affected community, but also the health workforce. If we don't have an educated workforce on hepatitis, then of course the information will not be getting to our patients.
Exactly. Knowledge indeed is the key. And on that note, you shared with us some very interesting resources that when our participants are finished with the webinar and if they have any more questions or they need more knowledge on the subject, you shared some key documents to consider. I don't know if you want to go back to that slide. I think you mentioned the Global Health Sector Strategy for Viral Hepatitis 2016 to 2021. You also mentioned the Regional Plan of Action for Viral Hepatitis 2014 to 2019. And I think you also included the Consolidated Hepatitis Strategic Information Guidelines for 2019. I don't know if you want to break, the slide is up, great. And we can find these resources. I think there are links to these resources on the PANCAP website, but they're actually on the PAHO website as well.
They're on the PAHO website, they're on the WHO website. So really all you have to do is Google PAHO hepatitis and you will hit it and go to guidelines and you will see them all there. So these are free downloads, of course. And I think the key one for us today, testing and the treatment guidelines. There's a treatment summary, a policy brief on hepatitis B treatment. The actual hepatitis B treatment guidelines are about 200 pages long. They're intense. So I'd refer you to the policy brief on hepatitis B treatment, which is on the same webpage. And of course, for program managers, the Consolidated Hepatitis Strategic Information Guidelines, which are only about 20-25 pages long, so they're very brief and straightforward. And they will assist with the input of data into the Global Hepatitis Reporting System. So those are the key documents. Of course, any questions, you can email us or through PANCAP CARICOM.
Right, and I just want to mention to our participants, if you don't want to send your questions now, there's pancap@caricom.org. You can send your questions there. You can also email Dr. Shanti Singh Anthony and, or myself, and we'd be happy to pass the questions on to Dr. Walsh, and he'll send us the responses. I don't see any more questions at the moment. So I think it's an indicator, Dr. Walsh, your presentation was so fantastic that no one has any questions at this point. But we're so grateful to you. Any final remarks before we close?
No, it's just a pleasure. Thank you for the opportunity. We're here to support, and we look forward to hearing from you soon.
Great. Thank you so much again. So this brings us to the end of our webinar. You will receive a short survey when the webinar is ended. I encourage you to provide feedback on this webinar. It will help us to better serve you. On behalf of the PANCAP Director, Mr. Derek Springer, and the participants today, I want to thank Dr. Walsh for investing in the webinar and sharing his knowledge and experience with the partnership. I know Dr. Walsh has a very large portfolio, so I want to thank him so much for taking the time out to share this knowledge with us today. I think he also has a bit of a cold, so we really appreciate that you braved your illness to still provide us with this fantastic
and I wish there was effective treatment for those types of viruses.
But nevertheless, we really appreciate you being here this afternoon.
Great.
So I want to thank our participants who've joined us today as well. And as a reminder, the webinar was recorded and will be posted on the PANCAP website, the PANCAP YouTube channel, and links will be posted on our social media platforms. Please do join us for our next webinar. You will receive an email notification. And finally, do continue to stay engaged with the regional response. Visit our website, that's pancap.org, pancap.org. And you can follow us on social media, Facebook and Twitter at pancap.org. Again, thank you, everyone.